Welcome back to The Great Adventure, Pediatric Pulmonary Physiology. This is the 13th in a series, and we're dealing today with pulmonary function testing, part 5, the diffusing capacity. So this is The Great Adventure, Pediatric Pulmonary Physiology, and as you can see, we're in the 13th session out of 30. We want to approach this like with the enthusiasm of a kid in a candy shop. And so just to review what we've talked about pulmonary function testing and basically two pulmonary function testing pattern abnormalities. Restrictive lung disease, which are those characterized by small lung volume, stiff lungs, and obstructive lung diseases, which are characterized by increased airway resistance and decreased maximal expiratory flow rates. Today we're going to talk about diffusion, so oxygen diffusion in the lungs, the single breath diffusing capacity of the lung for carbon monoxide, measuring the single breath diffusing capacity of the lung for carbon monoxide, exploring what does the diffusing capacity actually measure, does airway obstruction elevate the diffusing capacity, and just for fun, can the diffusing capacity help us to understand lung growth? So first, oxygen diffusion in the lungs. So oxygen and CO2 transport across the alveolar capillary membrane is by passive diffusion. There is no active transport of oxygen or CO2, and CO2 is much more diffusible than oxygen. So in the normal situation, blood returns from the pulmonary arteries unoxygenated with a mixed venous PO2 of 40. It goes throughout the alveolar pulmonary capillary where diffusion occurs. The normal alveolar oxygen PO2 is about 100, and blood leaving the alveolus has a PO2 of almost the same as alveolar. Turns out diffusion for oxygen is not quite complete, but pretty nearly complete. If we think about diffusion, we have to think about the path that oxygen takes from the alveolus to hemoglobin. So oxygen in the alveolus here, there might be an impediment to diffusion across the alveolar capillary membrane, which would be referred to as the membrane diffusing capacity. And then the oxygen has to get into the red cell where it is confronted with a chemical reaction rate of oxygen to hemoglobin, and also the overall diffusing capacity is going to be dependent on the amount of hemoglobin in the lung at the time the test is done. So oxygen transport from the alveolus to the pulmonary can be diffusion limited or perfusion limited. That is, the question is what limits oxygen transport? So diffusion limited is shown here, perfusion limited is shown here. So diffusion limited gas exchange is characterized by incomplete equilibration between alveolar and pulmonary capillary PO2s. The rate of gas diffusion across the alveolar membrane is what limits its transport. That is, that's the major impediment. And O2 gas transport, even in normal lungs, is diffusion unlimited at extreme altitude, but not at sea level. And this is what this would look like. So blood enters with a mixed venous PO2 of 40. Diffusion occurs, but as you can see, it never gets to the level of the alveolar PO2. And finally, when it leaves, there's still a considerable gap between alveolar PO2 and pulmonary venous O2. So this slow equilibration is characteristic of diffusion being limited at the alveolar capillary membrane, or so-called diffusion limited gas exchange. In contrast, perfusion limited gas exchange is characterized by complete equilibration between the alveolar and pulmonary capillary PO2. Gas transport is limited by perfusion, that is, the amount of hemoglobin to receive oxygen. And O2 oxygen gas transport is perfusion limited at sea level. So let's look at this. So in this case, blood enters with a mixed venous PO2 of 40. And then you can see that diffusion occurs rapidly and is complete. That is, the PO2 in the pulmonary capillary blood is equal to the PO2 in the alveolar blood, really before the blood gets about a third of the way through the pulmonary capillary. And then no further diffusion occurs at this point in time. All right, so basically complete diffusion here, so that in this case, perfusion is limited, gas change is limited by perfusion. That is, once this equilibration is achieved, the only reason more diffusion does not occur is that hemoglobin is already 100% saturated. It can't take any more blood or any more oxygen. So in normal lungs, O2 gas transport is perfusion limited at sea level. There's an equilibration between alveolar and then capillary PO2 long before the red blood cell exits the alveolar pulmonary capillary. Therefore, there is no significant impediment to oxygen diffusion across the alveolar capillary membrane. That's important. There is no significant impediment to oxygen diffusion across the alveolar capillary membrane. And so what we can see here, the reason you don't get any further diffusion is hemoglobin is already 100% saturated here with a PO2 of 100. So there's no more room for oxygen, and therefore more diffusion does not occur. Since O2 diffusion is determined primarily by the amount of hemoglobin in the lung, it will not be increased in normal lungs by increasing the diffusion gradient, that is, by increasing the fraction of inspired oxygen. When I was in college, oxygen bars were all the rage, and people could go in and breathe some increased proportion of inspired oxygen. But this was a bit of a scam because if you had normal lungs going in, you did not get any more oxygen that diffused across your alveolar capillary membrane than when you were breathing room air because in both cases, your hemoglobin was 100% saturated. However, if somebody is hypoxemic, then oxygen diffusion can be increased by increasing FiO2 if initially the saturation is low and therefore can increase. So in normal lungs, one can increase oxygen diffusion by increasing oxygen uptake, increasing hemoglobin, increasing cardiac output, which is essentially the amount of hemoglobin per unit time, but increasing the diffusion gradient, i.e. the PiO2 or FiO2, will have no effect. However, if you have abnormal lungs and you are at rest hypoxic, then all of these things increase diffusion as well as increasing the diffusion gradient, or FiO2, which will allow saturation now to become 100% saturated. Limitation in oxygen transport, there is no significant impediment to oxygen diffusion across the alveolar capillary membrane. Thus, the thickened alveolar capillary membrane, as in pulmonary fibrosis, does not significantly affect diffusion. There are no diffusion defects described in animals or man which cause hypoxia at rest. So, for example, in pulmonary fibrosis, hypoxia can be explained by the alterations in pulmonary mechanics alone, and one need not hypothesize an additional diffusion defect to explain the hypoxia. We could, however, stress the system. So if we exercise somebody, we decrease the amount of time the red cell is in the alveolar capillary, and therefore potentially could decrease the amount of diffusion. If we perform this at altitude, then we decrease the diffusion gradient. That is, alveolar O2 is no longer going to be 100, but could be, for example, 60. So this would stress the system and potentially bring out a diffusion defect that might not be evident breathing room air at rest. So it turns out that at sea level, in normal lungs, oxygen transport is perfusion limited, but on the top of Mount Everest, extreme altitude, okay, as we'll learn down the road, transport is in fact diffusion limited. That is, the main impediment to diffusion is across the alveolar capillary membrane, not because it's different, but because the diffusion gradient across it is so low that basically it acts as if that's the impediment. So in normal lungs, O2 transport is perfusion limited at sea level. At the summit of Mount Everest, the diffusion gradient is so low that O2 gas transport is diffusion limited. When the diffusion limit is very low, it acts as if the alveolar capillary membrane limits oxygen transport. So what we have here is that as one increases altitude, now we're talking about extreme altitude here, the oxygen transport moves from being perfusion limited towards being diffusion limited. So this is the definition or the formula for a diffusing capacity. So the diffusing capacity is the amount of mLs of a gas that diffuses, and the mLs are measured in STPD, standard temperature pressure dry. per minute over which diffusion is measured, the time of which diffusion is measured, per millimeter mercury or torr diffusion gradient, which would be the initial PO2 minus the final PO2. All right. Now, there is a problem here. We are really most interested in diffusion of oxygen across the alveolar membrane, alveolar capillary membrane, but we cannot know the pulmonary capillary PO2. Therefore, we cannot calculate an oxygen gradient because we cannot measure the diffusion gradient. I said we cannot calculate an oxygen gradient, therefore we cannot measure diffusing capacity of the lung for oxygen in the lung. So we don't have this ability. We move to the single breath diffusing capacity of the lung for carbon monoxide. Carbon monoxide is a gas molecule of similar size and properties with oxygen. But CO is avidly bound to hemoglobin, much more so than oxygen. So there's virtually no dissolved carbon monoxide in blood. It's all bound to hemoglobin. Therefore, the pulmonary capillary P carbon monoxide, or PCO, is zero. And therefore, we can calculate a diffusion gradient for carbon monoxide in the lung if we can measure or calculate the alveolar carbon monoxide PCO. So here, the diffusing capacity of the lung for carbon monoxide, again, this diffusing capacity of the lung for carbon monoxide single breath equals alveolar volume. Okay, so this is going to be the volume in the lung at the time the test is done, times the difference in the fraction of alveolar CO. Okay, this is the initial CO when you inhale minus the exhaled CO. Delta T is the time over which diffusion is measured. The standard is 10 seconds. And PaCO is the diffusion gradient. Since pulmonary capillary PCO is zero, we know what that is if we can calculate or measure the alveolar CO. So how do we measure this? So the maneuver is done in this way. One has somebody breathe normally, take a full breath to total lung capacity to establish a constant volume history, exhale completely to residual volume, okay? Then inhale a gas which contains 0.25% CO and a tracer gas. Hold that for 10 seconds, exhale, and then collect a gas sample here. So here we have, again, volume history, maximal exhalation, then a vital capacity inhalation of carbon monoxide and a tracer gas. Hold this for 10 seconds. Diffusion occurs over this period of time, and then take an exhaled sample to measure CO and tracer gas concentrations. So, again, the technique is a maximal inhaled vital capacity breath of 0.25% CO. So we're in no danger of causing carbon monoxide poisoning, and 10% tracer gas, which is usually helium. Breath hold for 10 seconds at total lung capacity, and then exhale and collect an exhaled gas sample. The DLCO is basically is measured, depends on the volume in which CO diffuses. In fact, that's this alveolar volume. In 10 seconds, CO does not diffuse throughout the entire lung. So VA, alveolar volume, is the volume of the lung where CO is distributed, and it's measured with an inert gas by gas dilution technique, usually helium. So now this is a 10-second helium dilution. So again, we've inspired a vital capacity of this concentration over 10 seconds. This has diluted over some volume, but it's not going to be the complete total lung capacity. You can't get all this gas going everywhere in 10 seconds. So the beauty of this is that this VA, which we actually calculate using this the diffusion capacity measurement, is the volume over which carbon monoxide also diffused or dispersed within the lung. So basically the beauty of calculating VA to measure the diffusing capacity is that helium goes where the CO goes in the lungs. VA is a 10-second helium dilution measure of TLC, but rarely does it equal actual TLC because helium cannot distribute throughout the entire lung in 10 seconds. So the fraction of alveolar CO is not the inspired fraction of CO, that 0.25. It's less than that due to dilution of the vital capacity fraction of inspired CO into the alveolar volume. So basically, again, we have a constant amount of gas here. So the fraction of alveolar CO2 times alveolar volume, okay, equals the fraction of inspired CO2 times vital capacity. And therefore, we can calculate this, the fraction of alveolar CO2, all right, which constitutes the diffusion gradient, is equal to the fraction of inspired CO2, CO, excuse me, times the vital capacity divided by alveolar volume. And again, it's that 10-second helium dilution. Alveolar volume will be greater than vital capacity, but not as great as total capacity. Delta FaCO is the difference between the initial fraction of alveolar CO2 and the fraction of exhaled CO2 collected in the exhaled gas sample after 10 seconds of diffusion. Now note this is the value we calculated, not the FiCO. When do you collect the exhaled gas sample? Well, you need to clear anatomic dead space, or VD, which are conducting airways, which is about 2 mLs per kilogram. But the longer you wait, diffusion of carbon monoxide continues, which artificially increases the diffusing capacity. So you want to collect a small sample after the wasted ventilation or conducting airway volume has been cleared. So here we have this. So you want to collect a very small sample here after you've exhaled enough to clear the conducting airways. And here's an example. So this is a patient we did a single breath diffusing capacity on, and you can see a very small sample was collected here, and this was the diffusing capacity that was calculated, 31.3. Now in the same patient, same maneuver, if we increase the amount of gas collected, we increase the diffusing capacity because diffusion is still occurring as we're collecting this extra amount of gas. So you actually want to collect a small exhaled gas sample, as small as reasonably possible, not a large, half a liter sample. You want a small sample to get the most accurate measure. So collect a small exhaled sample after clearing conducting airways, collecting a large exhaled sample or waiting for further exhalation artificially increases the DLCO value. Delta T is the time when diffusion occurs, and this is calculated as a breath hold time. The standard is 10 seconds. It is assumed that one goes during the inhalation from maximal residual volume to total lung capacity instantaneously. That is, it's a maximal inhalation. The exhaled sample should be collected again as soon as possible to kind of narrow in this 10-second breath hold. So the important thing is that this is a maximal inhalation, all right? So you're going to inhale as rapidly as you can. This is going to become important in a few minutes. 10-second breath hold, exhalation, and then small sample collected fairly early. If one has obstructive lung disease, for example, one might not be able to inspire instantaneously, and so a variety of ways have been suggested to calculate the breath hold time, including examples shown here. But generally speaking, computer systems already do that for us. And note here, they're suggesting a small sample volume. Delta T is the time when diffusion occurs. Increasing the time for diffusion to occur will artificially increase the DLCO, i.e. slow inspiration from TLC and or late collection of exhaled gas. And this is artificially increased in airway obstruction, for example. The actual formula for the DLCO above indicates that uptake of CO is not linear, but is exponential. It's a natural logarithm here. Thus, the breath hold time should be as close as possible to 10 seconds. One cannot just correct time in a linear fashion and be accurate. The diffusion gradient is the initial P alveolar CO that we calculated, remember? The pulmonary capillary PCO is 0, since CO is avidly bound to hemoglobin. Therefore, the PCO, alveolar PCO, okay, is going to be equal to the inspired PCO times vital capacity over the alveolar volume. So it's going to be somewhat less than this inspired CO, depending on how big the alveolar volume is compared to VC and how much CO has diffused throughout the lung in that 10 seconds. So what does the DLCO actually measure? So again, we have this schema here. O2 in the alveolus has to get to hemoglobin. It must cross the alveolar capillary membrane, and this is referred to as DM, and it must also chemically combine with hemoglobin, which is the theta, and then this is also determined by the amount of hemoglobin in the lung. So in this sort of situation, the reciprocal of these capacities is additive. So the diffusing capacity of the lung, 1 over the diffusing capacity of the lung is equal to 1 over membrane diffusing capacity plus 1 over theta plus capillary blood volume. So this is where DLCO is the measured diffusing capacity, DM is the membrane diffusing capacity, CO hemoglobin chemical reaction rate is theta, and VC is hemoglobin in the lung when the test was performed. Now, as lung volume increases, the membrane diffusing capacity increases due to increased alveolar surface area. VC, as the volume of hemoglobin in the lung, has variable effects due to differential stretching and flattening of alveolar and extraalveolar blood vessels. We talked about these previously. As lung volume increases, the net effect is that the DLCO increases, but the DLCO is less proportionate than the increase in VA. Thus, the increase in DLCO with VA is not explained by an increase in membrane diffusing capacity. That is, these do not correlate in a linear fashion. Exercise, Mueller maneuvers, and the supine position all recruit pulmonary capillaries and increase the diffusing capacity. The Valsalva maneuver, lung resection, and anemia all decrease pulmonary capillaries or blood capillaries and reduce the diffusing capacity. Thus, the DLCO is most affected by the amount of hemoglobin in the lung at the time the test is performed. In case of anemia, the DLCO needs to be corrected for decreased hemoglobin. The pulmonary function technicians at Children's Hospital Los Angeles will correct the diffusing capacity for the most recent hemoglobin in the medical record within 30 days of the test. Beyond that, the hemoglobin may not reflect the clinical situation of the patient when the test is done, and we simply report uncorrected hemoglobin. Now, why is this important? True clinical story. A number of years ago, I saw a young lady with thalassemia who was referred for pulmonary hypertension. So I did a history physical, all that kind of stuff. There was nothing that suggested anything like pulmonary hypertension. I mean, there was no history of syncope or any kinds of problems, shortness of breath, nothing. She had in fact seen cardiology and an echocardiogram was normal. So I asked her why she was here, and she said, well, she had done pulmonary function testing in our laboratory about a month before the visit. And so I went and found that the diffusing capacity was indeed low, which correlates with pulmonary vascular disease. But of course, she has thalassemia, which is an anemia. And as luck would have it, she had a CBC drawn on the same day. So when I corrected the hemoglobin as per this formula, it turned out to be normal. So in fact, she did not have pulmonary hypertension. She just had a diffusing capacity, which was uncorrected for hemoglobin. And because her hemoglobin was low, and it was interpreted as probably consistent with pulmonary vascular disease. So it is important when you can to correct the diffusing capacity for hemoglobin. The hemoglobin maneuver is only 10 seconds. Thus, the DLCO measures only the best ventilated regions of lung, the shortest time constants. So it may not measure diffusion in poorly ventilated areas of lungs. That's just something to keep in mind. Measuring the diffusing capacity. So oftentimes people divide the diffusing capacity by lung volume. Okay, so the diffusing capacity here, lung volume is incorporated. So the larger the lung volume, the larger your diffusing capacity. But we have better ways to measure lung volume. So we're often interested in the diffusing capacity corrected for VA, or the so-called DL over VA. In some places, especially in Europe, this is called the KCO, or transfer factor. And it simply equals the diffusing capacity divided by VA, as shown here, transfer factor. Should you measure the DLCO or the KCO? This is controversial. Some studies suggest that the diffusing capacity alone is a more sensitive test to detect interstitial lung disease than the KCO. Why? Well, the DCO also includes a measure of lung volume, and many of the lung diseases where we're most interested in the diffusing capacity, pulmonary fibrosis, uh, interstitial pneumonitis, pulmonary hypertension, etc., often also include restrictive lung disease. So if the parameter that you're measuring is essentially including a measure of total lung capacity, then it's going to be likely or more likely to be abnormal. But at least in my mind, it's not really the diffusion across the alveolar capillary membrane or into the hemoglobin that is decreasing the diffusion capacity. In this case, it's simply the fact that there is, in addition, some restrictive disease. So yes, you'll find a number of papers that say the diffusion capacity is more sensitive than KCO, but the reason is that lung volumes are often decreased, and it's not really what we're often interested in looking for. As mentioned, the DCO will be larger with increased lung volume, will also be smaller with restrictive lung disease. KCO is DLCO divided by lung volume, so it is normalized by lung volume, and the KCO will not increase with increased lung volume or decrease with decreased lung volume. The diffusing capacity is influenced by lung volume and gas transfer. The KCO is influenced only by gas transfer, not by lung volume. By reflecting both lung volume and gas transfer, the DLCO may be, quote, more sensitive, unquote, than KCO to be abnormal in interstitial lung disease. We perform the KCO or DCO to tell us about gas transfer, not lung volume. There are easier ways to measure total lung capacity, so we prefer to correct the DLCO for lung volume and to focus on gas transport. Own personal preference, people who prefer to use diffusing capacity as a raw value are not wrong, they're just different. So, does airway obstruction elevate the diffusing capacity? At Children's Hospital Los Angeles, we do not routinely measure the DCO in patients with airway obstruction, i.e., CF, asthma, etc. Why not? So, this is the Hospital for Sick Children. When I was there during the golden era, 1975 to 1977, it was actually their 100th anniversary at that time. And here I am with my mentor, Henry Levison, myself, colleagues Mark Catan and Craig Mellis, who were also fellows with me. So I just got to Toronto. I was there, and I was there as a research fellow. And Henry came up and asked me, have you ever noticed that the diffusing capacity is high in many of our CF patients? Well, of course, I hadn't noticed that, but the Hospital for Sick Children at that time was known for huge numbers of patients. The cystic fibrosis care center at that time had about 650 cystic fibrosis patients who came from all over the province of Ontario, which, if you look at a map, is huge. Patients were coming from Thunder Bay, which is 1,000 miles from Toronto. With this wealth of data, I just had a quick look. And it turned out that normals had about 100% predicted DCO, but patients with asthma as a group had an increase, and patients with CF as a group had an increased diffusing capacity compared to normals. I might have expected the opposite. So we then looked at this with respect to the airway obstruction. And so what I did was to plot diffusing capacity against MMEF, which is actually FEF 2575, for CF patients, each of these dots representing an individual PFT. And you can see that in general, the diffusing capacity was higher and above predicted normal for the most obstructed patients and gradually fell as their lung disease became more normal. Although not quite as extreme, this was also true for asthma, as you can see. More airway obstruction, higher diffusing capacity. Just to be safe, when we compared the percent predicted DCO against arterialized oxygen tension, or PaO2, there really was no relationship here. It was about the same, no matter what oxygenation was. So then what I did was take a group of us, so fellows and some pulmonary technicians, and I took a cork and drilled some holes in it to mimic an airway obstruction. And I had all of us perform a diffusing capacity, which we did, and then perform the diffusing capacity again through the obstructed airway. And this is what happened. Each line is an individual patient. So you can see that virtually everybody went up with obstruction. So airway obstruction, their KCO went up. Now, I will just add that we corrected these for flow rates. So with obstruction, obviously, we couldn't inspire or exhale as fast. We had a flow meter and had people match these flow rates in the control situation. So that was not the difference. And in fact, if we look at the DCO in the control versus obstructed, you can see the difference here. And the KCO control versus obstructed, you can see the difference here. In both cases, statistically significant. Next, we took a group of asthmatics, and after treating them with bronchodilators, if they had a bronchodilator response, we measured their diffusing capacity again. And those asthmatics who had an improvement in airflow following bronchodilator had a fall in general of their KCO. And this is shown again here. DCO in the control, following bronchodilator, it decreased. KCO in the control, following bronchodilator, it decreased. We then looked at this with respect to maximal inspiratory pressure. As mentioned earlier, Mueller maneuvers can actually increase the diffusing capacity, and Valsalva maneuvers decrease it. So what kind of inspiratory pressure did they take, or could we have them take, to do this KCO value? And it turned out the greater their inspiratory pressure, the higher the KCO. This was in a normal subject. And this was in a group of asthmatics. So in the same thing, the more negative mouth pressure, in this case it's times time, sorry, okay. So it's the pressure times the time was held, uh, showed you the increase in KCO, the more negative the pressure. So what is happening here? What we hypothesize is happening is that this maximal inhalation, remember you have to take a maximal inhalation at the beginning of the test, all right? So if you do a maximal inhalation, all right, and you have airway obstruction, you have to draw a more negative intrapleural pressure in order to generate that maximal inhalation. So now you're pulling on all structures in the lung, which now include blood vessels, all right, and opening them up during inspiration more than if you didn't have obstruction. So what's happening here is that you're increasing the amount of hemoglobin in the lung at the time the test was done. The diffusing capacity is increased in airway obstruction. The DCO requires a maximal inspiration. Maximal inspiration against narrow airways requires more negative intrapleural pressure, and this dilates intrapulmonary vessels, increasing the amount of hemoglobin in the lung as the time the test is done, thereby increasing the diffusing capacity, or the KCO. I will just add that in addition, when we submitted this for review, the reviewers doubted that this was the case. So we actually took a few asthmatics and measured their intrapleural pressure and showed that it was in fact increased during inspiration. So oxygen diffusion is limited by the amount of hemoglobin in pulmonary vessels. And the single breath diffusing capacity of the lung for carbon monoxide can be decreased by emphysema because it destroys alveolar walls and pulmonary capillaries, decreasing the amount of hemoglobin in the lung. Pulmonary vascular disease, which also destroys pulmonary capillaries, or anemia, which does not destroy lung but has less hemoglobin in the lung at the time the test is done. Can the single breath diffusing capacity help us to understand lung growth? So this was an interesting situation. So Children's Hospital Los Angeles, several years ago, we had a lung transplant program, and we were doing living lobar donor lung transplants. So lung transplant increases, lung volume, increases after lung transplant in children. So does the lung grow by increasing lung structures, i.e. alveoli, or does the lung simply grow by dilating existing structures? And can we use the diffusing capacity to help us figure this out? So living lobar lung transplants take an adult lobe and place it into a growing child. They actually take an adult lobe from two individuals and place one to replace each lung in CF, for example. The total lung capacity increases after lung transplant. Will environmental factors or growth hormones in the child cause the adult lobe to grow like it would as if it was in a growing child? So that's the question. The DCO is primarily affected by the amount of hemoglobin in the lung when the test is performed. So if lung growth occurs by adding alveoli and pulmonary capillaries, then the DLCO over VA should remain stable as total lung capacity increases. If lung growth occurs by simply dilating existing structures but not adding any, then the DLCO over VA should decrease as total lung capacity increases. Or if the lung growth occurs by adding alveoli, the DL over VA would remain stable after lung transplant when lung growth is increasing. If lung growth occurs simply by dilating existing alveoli, then the DL over VA will fall with time after lung transplant as the lung volume is increasing. Sushata Sritipayawan, who is a postdoctoral fellow in pediatric pulmonology here at Children's 1999 to 2002, and her mentor Marlon Wu, who was also a postdoctoral fellow in pediatric pulmonology here from 1988 to 1990, did this study. So they looked at 20 children who had had living lobar donor lung transplants, okay, age around 14 years, 40% males, and compared them with 11 children who had received cadaveric lung transplant, okay, cadaveric donors, mean age 52, 45% males. And you can see the majority of subjects in each group had cystic fibrosis as their reason for lung transplant. A few had persistent pulmonary hypertension, again, larger. Some of these had congenital heart disease. So this is change in height, um, months up to a year following both living lobar and cadaveric donor transplant. Really not much difference. This is the change in total lung capacity. So you can see living lobar donor lung transplants had a much more significant increase in total lung capacity than the cadaveric donors. This was the single breath diffusing capacity, not corrected, okay, in living lobar recipients over the course of the year and in cadaveric recipients over the course of the year. These are mean values. And this is the DL over VA. So you can see that in the living lobar, in the cadaveric donors, not much change. Living lobar donors, there was actually a fall in the DL over VA. So remember that if lung growth occurs by dilating existing alveoli, we would expect this to fall, which is exactly what we saw in this group. So although total lung capacity increases after lung transplant, the DLC over VA decreased. DLC over VA reflects the amount of hemoglobin in the lung when the test is done. The decreased amount of hemoglobin reflects decreased pulmonary capillaries. These were not anemic patients, by the way. And thus, TLC increased by dilating existing structures, not by adding new alveoli. So a clever use of the single breath diffusing capacity to answer this question. So what have we learned? Diffusion of oxygen in the lung is perfusion limited, at least at sea level in normal individuals. That is, it is limited by the amount of hemoglobin available to accept oxygen. Diffusion across the alveolar capillary membrane is not the rate limiting step of oxygen transport. The DLCO is also limited by hemoglobin in the lung at the time the test is performed, and in fact, primarily limited by that. The DLCO for carbon monoxide can be decreased by anything that decreases hemoglobin in the lung when the test is performed. Emphysema destroys alveolar capillary walls and pulmonary capillaries. Pulmonary vascular disease, likewise, and anemia decreases the amount of hemoglobin. The DLCO can also be increased by airway obstruction. So next time, we're going to be a little bit more clinical. We're going to talk about using pulmonary function testing for preoperative evaluation of postoperative risk. We're often asked to quote unquote clear patients for surgery. Well, what does that mean? And what can we in fact say? And that's what we're going to talk about next time. So thanks to our producer, director, Katie Winter, and thank you so much for joining us for this, The Great Adventure, Pediatric Pulmonary Physiology.